Hello everyone, my name is Amir Mohajeri and the title of my presentation is Opioid Misuse and Mental Health Treatment in a National Cohort of Adults. Let me give you a little background. The opioid crisis in the United States is widespread and rapidly increasing in severity, with a total of around 17,000 drug overdose deaths attributed to prescription opioids in 2016. The Society of Actuaries estimates of the total economic impact of non-medical opioid use in the United States from 2015 to 2018 exceeded $631 billion. Mental health and opioid use have a bi-directional relationship. It means some studies have found an increased risk of mental health disorders only in patients with opioid dependence, and other studies have found an increased risk of opioid misuse in patients with mental health disorders. Our purpose is to explore associations between opioid misuse and mental health treatment. Our method includes data inclusion and exclusion criteria, variables, and statistical analysis. We used a 2002-2019 data from National Survey on Drug Use and Health. We restricted the analysis to respondents over the age of 18. Our variables were demographics, opioid misuse, and mental health treatment. As a statistical analysis, first we calculated weighted descriptive statistics for participants' demographic characteristics, opioid misuse, and mental health treatment. And also we run weighted multivariable logistic regression to estimate the associations between mental health treatment and opioid misuse. All analyses were conducted with SPSS software, and statistical significance set at two-sided p-values lower than 0.05. Here is the results of the study. The sample of 214,505 consisted primarily of older adults, with 45.5% of participants being 50 years or older. There was approximately equal distribution of males and females. The majority of participants had an annual household income of $75,000 or more. Among the racial and ethnic groups represented in the sample, whites were the majority, followed by the Hispanics, blacks, Asians, and others. The majority of the participants were uninsured, and 89% of the study population reported they had at least one physical health condition, and 30.9% were unsatisfactory on their overall health. 4.2% of adults misused opioids, and mental health services were provided to 14.9% of adults. The results of univariate analysis for two groups, opioid misuse and non-opioid misuse, showed that there were statistically significant differences between the two groups on all characteristics. The majority of opioid misuse and non-opioid misuse subjects were diagnosed with at least one physical condition. In both groups, most participants were satisfied with their overall health and did not receive mental health treatment. For exploring the associations of mental health treatment and opioid misuse, we run three models. In Model 1, after adjustment for demographic variables, those receiving mental health treatment were more likely to misuse opioids compared to those adults without mental health treatment. In Model 2, after adjustment for variables in Model 1 and health insurance, we observe significant associations between mental health treatment and opioid misuse as well. In Model 3, after adjustment for variables in Model 2 and overall health and physical health conditions, the observed significant associations between mental health treatment and opioid misuse were somewhat attenuated. As a discussion, I have to say first, opioid misuse is a growing problem that requires prompt and proactive actions. Our results indicated that people receiving mental health treatment were over 2 times as likely to misuse opioids. Improving pain management among adults who have mental health disorders is critical to reduce opioid dependency at the national level. The essence of this study is the large nationally representative population-based sample of US adults used in this study, which improves generalizability. Our study has several limitations that need to be addressed. The first one is due to the cross-sectional nature of the data, causality cannot be assessed, which is a major limitation of this study. The second one is social desire bias may also affect survey data regarding sensitive information like substance dependence. At the end, I would like to thank Roseman University College of Dental Medicine Clinical Outcomes Research and Education for support this study. Thank you everyone for your attention.